We have 10 prizes to be giving away this morning, and we are not done yet. We have another 5 to be given away in the afternoon sessions. So, everyone ready? Is everyone ready for the lucky draw?
Yes.
Yes or no?
If you're not here, is the absence of the person the draw becomes forfeited? Is that how it is?
Okay, now let's do this. We have the also called the fish bowl. Here we invite maybe Dr. Homer. Can I have Dr. Homer? Or Dr. Mazia first? Okay, please welcome Dr. Mazia. We'll take 10. Yes, 10 names to be.
01928
It's already names, Nan. They're already putting names. Better. Yeah. Yes, by names. It's by names now. Better. God is there. It's in here. Don't worry. Shake, Dr. Mazia.
I tak tengok.
All right. Are the prizes ready? Okay. Now,
I baca.
you baca.
Sebab I pakai spek.
First one.
Sorry ya. Abdul Mukhtar tapi Dr. Ahmad Nazri.
Are we having here? Yay! He's here. Where's the prize? Okay, come. Okay. Can I please hear? Can?
Osman Aina.
Ah.
Actually. Aina, faster.
Kat. Okay, thank you. Congratulations, Aina. Next will be. Just read.
Profesor Dr. Hajah Adlina binti Sulaiman.
Our speakers yesterday.
Prof, are you here? Prof 1, Prof 2, Prof 3, next. Cepat. Jahat ini. Dr. Hanita binti Abdul Wahid. Dr. Hanita, are you here? Hanita 1. Oh, cepat.
We are here to stimulate the happy hormone. She said.
Okay.
The next one.
Dr. Edwin.
Our speakers again. No, I do it. Sorry, Edwin.
Dr. Edwin 1, Edwin 2, 3, Edwin.
There's no Edward here. It's Edwin.
Okay, next. Oh, ni yang jealous ni. Dr. Muhammad Norawi, Dr. Norman. Norman, I saw you somewhere just now. Dr. Norman 1, Dr. Norman 2, Dr. Norman 3. Oh, you want to take for him? Okay. Dr. Bala Chandran. Dr. Bala, are you here? Yeah. Okay.
When I said by everyone is lucky this morning. Sorry.
All right. Dr. Kenny. Kenny, are you here, Dr. Kenny 1, Kenny 2, Kenny 3? Done.
So fast and quick.
Okay. Dr. Kenny 1. Dr. Kenny 2. 2.5. 3. Habis, tutup. Ay. Oh, Alin, Dr. Nor Ashikin. Wow. Alin, are you here? No. Bukan dia. Dr. Aslin. Alin, faster, Lin. Oh, I have to take another two. Okay.
Yeah. Wow, I need to be announced this. Wow. All right. Congratulations for the lucky draw winners. This one worth, if I'm not mistaken. Yeah, I would love to mention that this is actually worth more than, yeah, it's worth that 500 ringgit, more than 500 ringgit actually. Thank you, Dr. Alin.
Okay, next, Dr. Widya Murni.
Wow, Dr. Widya, the lucky one from Indonesia. So, we have...
Oh, this is my classmate. Dr. Nor Aminah Jaafar. Amy, faster me. Dr. Fazilah binti Ngasiran. Fazilah Ngasiran. Dr. Fazilah. Okay. Betul-betul. Semua yang classmate I semua very lucky today. Cik Anissa, Cik Din. Cik Anissa, Cik Din. Ni form 5 punya classmate. Ni Cik Anissa. MPOB. They are one of the main sponsors and she also get the gift. Sahabat, lari laju lah sahabat. Dr. Hishamuddin Abdul Rahman. Dr. Hishamuddin Abdul Rahman. Baru nak cakap dan.
Thank you, Dr. Maza, and thank you for having here for that prize giving ceremony, and congratulations to everyone who won the prizes. All right, so the much awaited talk, over to you, Michelle.
Okay. For our next speaker, she is a member of the American Academy of Anti-Aging Medicine, A4M, a certified nutrigenomics practitioner in Australia, certified stem cell therapy in Australia, certified IV nutrient therapy, IHS board certified for advanced hormone therapy in Belgium, with honors of Fellow Royal College of Obstetrics and Gynecologists in UK, member of the American Academy and American Academy Board of Regenerative Medicine, fellow from the European Council of Aging Research and Education, former director of National Population and Family Development Board of Malaysia, founder and executive chairman of Prima Nora Medical Center and a senior consultant, obstetrician and gynecologist, and the healthy aging specialist. She is dedicated to the emerging field of age management medicine or anti-aging medicine and nutrigenomics. Let us give a warm welcome to Datuk Dr. Nor Ashikin Mokhtar.
Thank you, ladies, for the kind introduction. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. And good morning to fellow delegates, my friends, and some of my teachers are here as well. I'm truly blessed and I feel very honored. Thank you, Marzia, for letting me join to be part of this faculty. And I look forward for more future, I would say, sharing of knowledge and also learning. I'm forever learning. And this is something that while we're all here with like minds to make this a better world, a better community. As you know, I mean, some of you know, I just briefly should share with you, by gynecologist, being a gynecologist for the last almost 30 years now. Initially, I started off, if you say 30 years ago, there's only a handful of us, and I went through a very turbulent period of pulling out babies alive, and even having a record delivery of 25 babies in 24 hours. And, well, I was young then, but not sleeping, not eating, not even seeing sometimes my husband bring my clothes. It does have taken a toll on my health. And, but if you remember what Dr. Antonio was saying, everything happened for a good reason, and perhaps that was also the turning point, the transition, where from being a gynecologist, I have now actually incorporated, or I would say I've not stepped out of the box, I've extended my knowledge to include all these areas of nutrition, hormone optimization, and alhamdulillah, in this century, with the knowledge of the genetics, that makes the understanding of treating and managing my patient even easier, more comfortable, and more rewarding and safer. And every one of you here who are learners, this is the way forward where we have to integrate what we learn and not be too arrogant and just stay in one box. And the more we learn, the more we know how little we know. But that's how, I would say, practitioners, healers, we become better healers, inshallah. So without much ado, as you have met some great speakers, basically among all the speakers here, I'm actually the clinicians, which hopefully for what I have to share with you are knowledge from what I learned, and maybe by tomorrow morning you can even use that for your practice. And this is what I'm going to share, basically on hormones, and you had some hormones peak just now. So let's take a back seat now while you listen to what I have to share. Okay? So going through, this is what this is what I'm actually going through in the various part of my lectures. Now, we can't deny that hormones in aging and longevity play an important part, right? So basically, again, if you said, we heard more and more since yesterday, aging is these progressive changes associated with, I would say, an ever-increasing susceptibility to diseases, chronic diseases, which accompanies advancing age. Okay? So these changes create a normal physiological decline seen in middle and late adulthood. But having said that, the day you're born, you're aging. The day we're born, you're dying. Okay? So these are some of the theories, and some of them have been discussed yesterday. But for the point of my discussion, I'm just going to focus on the aspects of hormones, which is also one of my favorite topics as being a gynecologist. Now, what are the evidence? Just to share with you, hormones, and as we all know, they are natural chemical messengers, and hormones actually, they play a very important role in various aspects of our body's function. They are secreted in one part of the body, but yet transported in the blood to other parts of the body. Hence, that's why they are called hormones and endocrine glands, rather than just a specific organ itself. Hormones regulate and coordinate all major metabolic growth and developmental activities. And consequently, it affects the energy production, the cellular repair, replacement, and regulate genes. And hormones diminish with aging, among other things. And target cells, receptors for hormones and aging are also affected All right? So here you can see that majority of the hormones in our body actually decline with age, but however, insulin or cortisol rise. But even if they do rise, okay, the receptors are not as responsive as before. Yeah? Okay, so there's still this issue there. So for the first part of this lecture, I'm going to confine to women. So what happens to women hormones with aging with regards to this following hormones? So I'm just confined to just the steroidogenic hormones in the steroidal pathways before time constraints. Now, being a woman, and I see more women here as well, compared to men, as you can see, actually we women go through more hormonal fluctuations in our life than a man. And I think that's wonderful. So it's more exciting because we go through puberty, we go through adolescence, we go through I would say menarche, we go through pregnancy, breastfeeding, perimenopause, menopause. Wow, it's so colorful, like the rainbow. Okay? All right, so roller coaster rides are more interesting than just a slow, still ride. That's how I see it. Okay? But the sad part is, just to understand, okay, the hormones do come down, and it's not just until we menopause that it comes down. It actually does a decline even as early as the age of 30. And that's when most of my patients, or some patients, will come with different presentations, even at that age. Okay? All right. Why? Because again, when we talk about women hormones, it's quite actually closely linked to the reproductive system, the ovaries, and our oocytes, ladies. Well, there's a diminished returns with age and time. Okay? All for a good reason. So no worries there. Okay? All right, so as we sit here, okay, some of us are without our ovaries, without our oocytes, including myself, but at the same time, some of you now, okay, well, it's diminished, and that also, and the sad part is some depending on the condition that you're going through, some sooner and faster than others, again, depending on what's happening in your body, okay? Okay, so there are other conditions that adversely affect serum levels. I'm going to confine to estrogen and progesterone, and this is where you can see clinically, all right, with regards to estrogen and progesterone, you can see these changes quite markedly, how it's affected after pregnancy. Okay, you can see the before and after changes in this lady. Okay, all right. With sports training, there's also sometimes there's a decrease in this estrogen as well, and some with strenuous exercise will not have your periods. Okay, the cortisol steal, tubal ligation, and I'm one of the gynecologists has not done tubal ligations for more than 15 years. For I would say my faith, right? Being that tubal ligation is actually destroying something that's healthy and normal, and if you have options like the Mirena that gives us even better than tubal ligations, which still have a 1 in 3 chance of being pregnant, an ectopic pregnancy, whereas that's why I would say always keep our options open, ladies. Okay? All right. So yes, with tubal ligation, there's a destruction to the blood flow. There's also an impact on possibility also on the estrogen level. Okay? All right. Also, oral contraceptive pills, okay? Again, because oral contraceptive pills, being a synthetic hormones, increase the sex hormone binding globulins, will decrease the testosterone level, cause muscle wasting, decrease libido, dryness vagina, and also I would say, well, there's also an impact in the sexual health. Again, I'm one of the gynecologists now who do not give oral contraceptive pills because there are other options. And I always tell my patients, if you want a second opinion, there's thousands of other gynecologists even in Kuala Lumpur. All right, okay. Other hormones also other conditions can affect hormone deficiency. So I'm just going to highlight some clinical signs, okay, so that you can actually pick out with regards to the final effects of the hormones on target tissues. And this is important because this is what has the woman come in straight away, you can actually make some diagnosis what she's going through even before she says anything. And this is what I do when the patient walks into the door. You can already sum up the possibility that what she's probably going through. Okay? So a good knowledge of the clinical signs and symptoms of estrogen and progesterone deficiency is essential. All right, because sometimes the patient don't tell you, hey, I think I've got progesterone deficiency or I have estrogen deficiency, because very unlikely for someone 30-year-old to tell you that, but in actual fact, she could be going through that. So these are some of the clinical signs of symptoms that I'm going to share with you in terms of identifying them, okay? With regards to estrogen, okay, estrogen is so important. It's so important for women, but also for the men. And it affects the whole body, literally from inside out, from top to toe. Whether it's the brain, whether it's the eyes, whether it's the heart, whether it's the breast, whether it's the lung, whether it's the liver, that is the cholesterol, whether it's the bone, the skin, the bladder, the vagina. It has 400 over functions with regards to the human body. So, if it's got 400 functions in the human body, can you imagine what happens when that declines? 400 functions are declining. Are we going to accept that? Well, if we do not know, then of course, he said, oh, that's Mother Nature. But with that knowledge, it would be sinful for us, for me, not to now help my fellow women to have a better quality of life. Okay. So the most drastic change that a woman experiences would definitely be menopause, whether it's surgical menopause or natural menopause, because that would mean the end of her menses, the end of the menstrual cycle, but more importantly, also a rapid decline in the hormones. Okay? So some of them may present with menopause symptoms like hot flashes, headaches, irritability, insomnia, aches and pains, some ants crawling on the body, lack of libido, forgetfulness, dryness of vagina, mood swings, just to name a few. Okay? Some are so severe, I have patients coming in, hey doc, if you don't do something to me, I'm going to kill my husband. So help me God. Okay? Majority will just maybe have one or two or say, I don't feel anything. What's happening? All right? I mean, I'm fine. Okay, sorry. Another 20% said nothing, but majority will have just one or few symptoms. Okay, so why consider hormone replacement therapy? Definitely for relief of symptoms, because if you will take herbal therapy, it's only usually for 6 months, and even if you don't give any herbal therapy, within 6 months to a year, the menopausal symptoms will go away. This is what the hot flashes and the palpitations, but the chronic conditions, the 400 other functions that are deteriorating is ongoing. So that's why we do give, that means the hormone therapy, either for prevention of memory loss, for heart health, for bone health, for cellular repair and growth, and for a group of all of the other things. Definitely also for better relationship if she whether it's married or not married, or for the family or for the community as a whole, okay? For better quality of life, and now also, preferably also, possibly also for prevention of Alzheimer's. So what we see externally is actually happened much, much earlier. All right, as I said, the hormones start to decline even at the age of 40, not just until she has no menses, you see. So this is a state of accelerated aging when definitely there's a drop in the estrogen. And we can see this as manifestations. Some women will have thinning of the hair or hair loss. They start to have fine lines. The face looks a bit pale. Sometimes you might see some hollowness on the face, okay, right? Or dry eyes. That's the complaint that they say, okay. Or some says, I think I need to go for breast implants now, okay, all right, because my breast is shrinking. So these are some things that we worry about. The stenosis of the breast, and of course also again because estrogen plays a very high impact on the breast issues. With sometimes even as the estrogen is dropping, because the rate of drop of estrogen is actually not equal to the rate of drop of progesterone, they might even have what we call it, although the breast is, they may also present with what we call breast tenderness, okay? All right. Of course, the more serious conditions that we're also afraid of is osteoporosis. Not unusually also with a drop of estrogen because of dryness of vagina, a decreased libido. Of course, there will be painful sites, also so-called loss of femininity as well. And if you see in terms of, with regards to estrogen and progesterone, they're usually the opposite of each other, whether it is the beneficial effects or whether it is also the, what we call it, the adverse effects. So on one hand, if you have estrogen, estrogen gives you good mood, gives you more energy. But if there's too much, then of course that's erratic. But progesterone is the natural Xanax. It's a hormone of calmness. Okay, but again, so that means if there's too little progesterone, with progesterone deficiency in the menopausal, then you get nervousness, right? And too little estrogen, then you have fatigue and tiredness. You see, so these are some of the marked difference between progesterone and estrogen deficiency. Okay, other things we can see, as I mentioned earlier, the patient will look stressed, the patient will look irritable, and that's again signs of progressive deficiency in progesterone, and some of the features that you can see as well. In estrogen deficiency, I mentioned again ptosis of the breast, and also there's increase in belly fat. Okay, all right. Okay. So as the hormone declines, if there is unevenness, particularly so just around the perimenopausal, there's estrogen dominance, there's also increased risk of growths like fibroids or endometriosis or ovarian cysts. Some of them have that presentation. So that's the reason why, as I said, we need to have a balance in order to have better improvement of life. Okay, so these are some of the other things that are also associated with a decline in the hormones. Okay. Inflammation of the joint, rheumatoid arthritis, or lower bone mass osteoporosis. Okay, there's of course also increase in risk of cardiovascular disease, okay, because of the abnormalities in the cholesterol level. There's less of loss of relaxation of the vascular wall, increased risk of cardiovascular disease with the menopause, and with the menopause, the rate of cardiovascular disease, we equate that of men. Why? Because again, with loss of estrogen, there's also a decrease in the nitric oxide, and that's where you have less dilatation of the arteries. So here again, giving hormone replacement therapy not only lower atherosclerosis, but also will help in the, I would say, dilatation of the blood vessels later on. With regards to the brain, of course, a decrease in estrogen is not just about mood swing, tiredness, lethargy. Estrogen is important for neuronal growth. Estrogen is important in the long term, also prevention of Alzheimer's. Okay, treatment of women with hormone deficiency. So what do we do? Now, menopause is not your fault, okay? And now we can do something about it. And I'm just so excited now because if you've known me, let's say 15 years ago, where I was also the chairman of the Public Awareness Committee for the Malaysian Menopause Society, I was all out. Literally, I visited every state in the whole of Malaysia promoting educating women on menopausal issues and hormone replacement therapy. That was around the year 2000, just about before the WHR report came on. And what I was actually talking about was hormone replacement therapy with synthetic hormone. So in the last 15 years or so, with the knowledge of integrative medicine, this is where I have actually swung more away from synthetic hormones into helping the woman with menopausal issues, estrogen replacement with bioidentical hormones. Okay, bioidentical hormones means they are biologically identical to our human body, to what the ovaries are producing, to our steroidogenic pathways, and this is where I found, and in my 30 years as a gynecologist, that more and more women are benefiting for it. And as I said, because I've refrained from any synthetic hormones for the obvious reason where there's issues where considering elevated liver enzymes or gallstones or even risk of hypertension, because you have less production of nitric oxide with synthetic hormones than if you give if you give bioidentical, and preferably bioidentical transdermally. All right, so there's a lot of, I would say, opinions on how the routes of even bioidentical hormones should be given, but from the cumulative reviews, I would say, from the teachers that have the advantage of knowing whether it's Michael Klaus or Michael Clance or Dr. Thierry Hertog, a good friend of Professor Frederick himself, Pamela Smith from A4M or from Europe. So this is where the consensus here is, if you want to be safe, transdermal is the way, and if you want to be safe, you must know the estrogen metabolism well enough. And this is where, with the knowledge of genetics, it is definitely much safer if you know the woman estrogen metabolism. So the right choices of giving hormone replacement therapy with bioidentical is even safer. Let's look at some of the studies. So what I want to share with you here, okay? So in the studies, so looking at postmenopausal women, for those who have hysterectomy, that if they're not given hormone therapy, most of them have an earlier death, okay? And with regards to women, some published studies shows that there's a 28% reduction in mortality in menopausal women under the age of 60, particularly improved quality of life for those who are on hormone replacement therapy, okay? What else? When you want to give hormone replacement therapy, why bioidentical? Because we have 3 natural hormones. So if they say estrogen causes breast cancer, I mean, people are just throwing that around. Your patients say, oh, I don't want hormones, it causes cancer. All right, that's because the media is the greatest culprit. Because when I was doing as chairman of the Public Awareness Company Hormone Therapy, there's a time when CAP came up with a statement, if you want to have a heart attack, you want to have stroke, all right, or you want to have cancer, take hormone replacement therapy. And I really have to go around the whole of the country to do damage control, just to assure them, understanding, look, if ever that's the case, then in the young woman, the highest hormones will have all that. Why menopausal women? And why in Malaysia we do mammogram screening at 40? Why in Europe at 50? Because we're getting cancer at much earlier age. The demographics are different. In Europe, we're getting cancers at later age. So that itself tells you again that there must be, that obviously the statement is contradicting, or the statement is confusing. And we have doctors have to correct that and assure the patient, and with the right knowledge and sharing with them, look, there are 3 hormones that you have in the body, okay? All right, it's not the hormones that cause cancer, but it's the metabolites. And more than that, you heard yesterday's lecture, Dr. Antonio, lifestyle, stress, okay, 10% is the genes, the environment that you eat, the kind of food that you take, okay, so it's not just the hormones. But basically, again, understanding we have 3 hormones, estrogen, which is mostly what's left in the menopausal, all right? And the primary function of estrogen is actually to provide reserve source. The main source of estrogen in the menopausal woman is from her fat cells. So the more fat you have, the more estrogen you have. All right? Okay. With regard to estradiol, it's actually the most active hormone, and it's 80 times more potent than estradiol. Estradiol is the weakest of all the hormones, but as I always said, in its weakness is its strength, because with estradiol is how you can actually prevent cancer. Right? Okay, so this is how, just to understand this pathway, if you want to give hormones, you must have this in front of you, you must have this on your table, you must understand how estrogen is produced from testosterone, how estradiol, estrone, and estrone, where did it come from, and at the same time also understand also the receptors, the alpha-beta receptors, okay? All right, so estrogen has got 2 receptors, the alpha and the beta receptors. The alpha receptors increases the cell growth. You see that in the breast, okay? The estrogen receptor beta decreases cell growth. You see that mostly confined to the colon. So that's the reason why, even in the WHO report saying that if you are on hormone replacement therapy, you can have a reduction in colon cancer. All right, so here, so understanding these issues, and also with this knowledge that estradiol equally activates alpha and beta, that's E2, and estrone selectively activates receptor alpha, whereas estrol, okay, preferentially binds to receptor beta. So that's why if you're if you want to give hormone replacement therapy, bioidentical, it must be biased, not just estradiol. So that's one of the disclaimer I tell my patient. You want to go long term, bias. And this is also what I've just learned from my trip back from the Clinical Andrology Conference in Houston, Texas, just about 2 months ago. you can actually go on giving hormone replacement therapy as long as she hasn't got Alzheimer's. In other words, as long as she can remember to use her hormones, let her use. And when can you start? Any age. 60, 70, 80? Even if she's starting for the first time. Why? 400 functions are declining. You want to improve that? Right. But of course, not that you start like that. Please, the protocol. Make sure you do the screening, whether it's ultrasound of the breast or the mammogram, the ultrasound abdomen, the full blood test to see whether other indication. No surprises. If they don't do that, I'm not going to manage you. There are many other doctors who can manage you shortcuts. I don't do shortcuts. And you should not do that as well. Do not compromise. Okay? All right? And do not be fearful, because if you do that, you do not be afraid of patients going to other doctors and not coming back to you. Always believe, okay? You're risky, all right? Your risk, that means whatever that you're going to earn for the rest of your life, it's already determined in utero. As a Muslim doctor does, I believe. So what? You have another doctor open next door. Mine's already determined by God. I'm not afraid, all right? And if you always have good intentions for your patient, they will come back to you. So I always share with my patients, because now I have actually reduced certain part of my gynecology training and share that with my other doctors, the younger doctors. Okay? All right. Now, so treatment with natural estrogen is why compounded, because just as we are different on our fingerprints, we're also different in our needs as women. So why would one pill will fit all? So that's again why, to me, it's just common sense. It just doesn't make sense anymore. It just doesn't gel into me why I should be given synthetic hormones anymore, right? And I said, bias, not trias. You do not need any estrogen, okay? So synthetic estrogen is not the same. It's from, for example, equine estrogen and all that. So it's actually derived from a horse, who's actually totally chemically different from a human being, one more female. Right? So medically, natural estrogen means that it is the same chemical structure that the patient is born with. I'm repeating that. That's it. Just drill that in, okay? It may or not come from a plant. Okay, some say, oh, it's not plant-based, so it's not halal or something. Okay, whatever it is, the choice is, I'm not going to do that path for now. Natural estrogen helps to protect against many things, as I said, in terms of cardiovascular risk. So this is a study that shows that compared to natural estrogen, the gene transcription of endothelial nitric oxide synthetase was 30 to 50% lower in response to equine estrogens. Hence, when they did a WHI report, when they gave conjugated equine estrogen, that's why it was not cardioprotective. The main reason where they actually enrolled 160,000 women from the age of 50 to 79, God knows, with different demographics, and given them the conjugated equine primarine and Depo-Provera, was to see whether it's cardioprotective. And they failed. And it was stopped because it failed. Because again, the selection was biased. Some of them already have established diseases. More than 50% were obese or smokers. So that it was an unfair trial. So again, do not be critical, but be analytical when you have such study reports. Okay. Besides knowing the alpha-beta receptors, you must also know the estrogen metabolism through the liver, knowing that actually goes through phase 1, phase 2. So that's why liver health is important. Okay. Liver health is important. It's supporting it with the right nutrients, with the right kind of food. Okay, so again, if you have a fatty liver, it's going to impair that. So hence why you have to do ultrasound liver, because more than 50% damage, then you can see it on ultrasound. In the blood test. So blood test alone is not adequate. You have to do a comprehensive check before you start HRT. So there are two major pathways of estrogen metabolism. The major pathways are the 2-hydroxyestrone and the 16-hydroxyestrone, and the minor pathway, the 4-hydroxyestrone. Okay, so with the knowledge of, again, genetics, which again, alhamdulillah, I'm very grateful to God for this knowledge, because it's only in this century that the human genome was unraveled. Okay, and we know now the impact of nutrition on the genes. That's nutrigenomics. So please go out and understand how that actually helps us to help our patient better. So here again, if you have an abnormality in the cytochrome families, like the CYP genes that are, that's dysfunctional, so there's diversion of the estrogen more towards the 4-hydroxy pathway or the 16-hydroxy pathway. And if there's no methylation, so that's why the risk of having more, or call it the harmful metabolites. So the The most harmful metabolites are actually the 16-hydroxy and the 4-hydroxy metabolites. Okay, these are carcinogenic. It's quite a mouthful. So what happens over time? Cancer doesn't happen overnight. Cancer happens over time. So initially, the patients will have symptoms of perhaps a breast cyst or ovarian cyst or endometriotic cysts or fibroids. So these are actually telltale signs that perhaps this is where the pathway is going, because this is the one that's actually promoting the growth. And this is where we need to support the woman in diverting it to go through what we call it the healthier pathway, the 2-hydroxy pathway, all right? And you need the methylation there. Of course, Edward has the test now to do the urine test of the ratio of the 16-hydroxy, the 2-hydroxy to 16-hydroxy ratio. That is some cost issue. It's a great test. I do believe it's about 1,000 ringgit. Yeah, okay. So that's one option, but the other option to ensure that the patient has good methylation is to look at the homocysteine, because that's where most methylation comes from the homocysteine pathway. So here, just to share with you that measuring homocysteine is about 100 plus, so that's an option of measuring, not as accurate as 16-hydroxy, but nevertheless, it's still an indicator that can say, oh, she's having healthy methylation if the homocysteine is in the 4 to 7 range, as opposed to if it's in the high range of homocysteine levels, right? Okay, and the research is supportive again, which shows that the 2-hydroxyestrone proposed is protective, all right? It's also chemoprotective against mammary cancer. It's anti-proliferative and induced apoptosis. The 16-hydroxy is found to cause abnormal breast cell proliferation. So this is the ratio that I was talking about. So a low ratio will increase a risk of breast cancer. A high ratio will increase osteoporosis. So this is... Sorry. Okay. Coming back. So this is what we need to encourage, all right, where we want to have, where in this case, if it goes down to this pathway, there's no further effects. If you're giving the patient hormone replacement therapy, and that's why we need to support with the right nutrients to ensure that she's got good methylation here, okay? And we want to divert it. And there are means of doing that, and then these are some of the ways that you can actually improve methylation, okay, with these supplements. And again, studies show that if it goes more through the 4-hydroxyestrone pathway, of course, then you will have these are the risks of cancer growth and all that. Okay, all right. So what goes through that pathway? Oral contraceptive pills. What goes through that pathway mostly? This minor pathway, synthetic hormones. Okay, so natural hormones are it's manageable because you can regulate the amount. Remember, we are special, all right? So the amount varies to individual. So you don't need like one dose for every patient. So that's not right, okay? So again, I repeat, okay, going through this 2-hydroxy pathway is what is the advantage, and you can even simply improve it to this healthy pathway by adding DIM to the patient, particularly so if you've done the genetic analysis of the patient and she has the cytochrome CYP1B abnormalities. Yeah? Okay. Now, as much as I say good things about estrogen, all right, it's like the Jekyll and Hyde, okay? This family hormone, at one time, it nourishes you and makes a woman, but at the other end, all right, it can also make her like a devil, okay? All right, so, yeah, sometimes they said, okay, if you have excessive estrogen, this is what you may look like, okay, as I told him, all right? Okay, so this is where they present with PMS-like symptoms before the menopause, okay? They have migraines, they have headache, they have breast tenderness, they get tired, they get lethargic, right? They have, erratic moods. And this is sad because this is also the stage where some of my patients are also referred to psychiatrists, unfortunately, okay? But if you understand that this is what's happening to her, which is actually natural and physiological, this division, that there is a decline in the hormones, but because the decline is not equal, where the drop in progesterone is 75% more than estrogen, that's why you have a condition called a relative estrogen dominance, even though the estrogen is declining. Okay? All right. And estrogen dominance can be brought about by many things. Okay, so definitely just now with stress, some of your estrogen has gone up as well, not just the cortisol, right? Okay, the kind of diet, the high carbohydrate diet, and what more? The diet now is adulterated, particularly our animals are injected with hormones. The chickens are within 3 months are instant chickens, or the cows, or the dairy milks, and the lies that we see on television that you have to drink more milk, okay, and that's why you get more hormones, you get more antibiotics. You have many, many issues. It's not just hormone imbalance. You have leaky gut syndrome from the damage to the gut lining, with and a whole list of things that cause this imbalance. Okay, all right. So again, we see that birth control pills, synthetic hormones can cause that. So excess estrogen, taking too much estrogen, okay, will also impact a limitation estrogen. So you have to be wary of which pathway is going. All right, particularly so more if the patient is sedentary, and the diet is high in carbohydrates, okay, and there's a lot of environmental toxins, especially if you're living in Kuala Lumpur. Maybe not if you're in Jendabai or maybe in Kota Baru also, maybe less xenoestrogens there. So these are some of the things that's happening naturally every day. So you have to understand and take that and take note of, again, not just how old she is, but family history, but the kind of lifestyle, what she eats, so what time does she sleep, because that also can lead to insulin resistance and estrogen dominance, and how often she eats outside, because that also means that she has poor control of the kind of food that she takes that can all then cause all this hormonal imbalance. All right, so again, symptoms of excess estrogen can cause also other conditions, insomnia, foggy thinking, mood swings. I've gone through that. Okay, versus progesterone, which is just the opposite. If estrogen is proliferative, that causes increased growth in the lining of the uterus, that causes the woman to have heavy periods, irregular periods, and what do you call it, menorrhagia. Progesterone will have the opposite effects of actually controlling that and also calming the patient down, and also can also prevent endometrial or even breast cancer. Okay, all right. I mentioned about the other factors. Why obesity? Because when you have fat cells, you have more estrone, and that's where estrone is more susceptible to the alpha receptors and more carcinogenic if it's in excess. And also, alcohol will interfere with the estrogen metabolism in the liver. Yeah? Okay, DIM is one that can divert it to the healthy estrogen pathway, but I always show my patient this because these are the other options. In other words, whether it's the omega-3 fish oil, whether the B vitamins, whether the antioxidants, or the DIM or the chrysin, or I3C, but also simple things like the cruciferous vegetables, the cauliflower, the broccolis, all that will also help in the healthy estrogen pathway, right? Okay. Coming to progesterone, okay, progesterone, as I said, which is the yin and yang, okay, there is this confusion in what they call it, mentioning of hormones, because in conventional medicine, they lump progestins also has progesterone, which is totally wrong, okay? Progestin is synthetic. It's totally not what our body is used to. Progesterone is progesterone, okay? So that's the reason when they had the report that increased risk of breast cancer, it's with the Provera, medroxyprogesterone acetate. That's a WHO report. We're talking about progesterone as a bioidentical hormones. Two different things here, all right? Okay, so progestins increase the bad cholesterol, decrease the good cholesterol. Progestin against, well, the only thing good about progestins, for example, like having a Mirena, it's protective against the womb cancer. But at least in Mirena, it just stays put there in the uterus rather than more in the systemic circulation, all right? So compounded progesterone is the way forward, and if the patient actually has insomnia, then I would actually give per oral rather than transdermal. All right? Okay. So progesterone per oral also helps to prevent breast cancer better than transdermally applied progesterone. So these are some clinical studies that show that natural progesterone effects which are not seen with progestins, and these studies have shown that progesterone does not induce estrogen-stimulated breast cell proliferation. Okay? More studies shows here again, if you see, women with the highest level of progesterone had regular cycle, had 88% reduction in the risk of developing breast cancer. And another study in 1,000 women who were deficient in progesterone had 5 times increased risk of developing premenopausal breast cancer and were 10 times likely to die from any form of cancer. Okay? All right, natural progesterone effects not seen with progestins. Okay, natural progesterone has been shown to decrease the risk of developing breast cancer. This are the studies that I've shown. That's associated with that. Okay, women who use progesterone in combination with estrogen have no increased risk in developing breast cancer. Okay. Again, natural progesterone effects not seen in progestin. There's a 40% increased risk of developing breast cancer in women who use estrogen with progestin. Okay? In women who use estrogen combined with progesterone, there was a trend towards decreased risk of developing breast cancer. Estrogen-progesterone ratio is important. At the same end, prolonged use of progesterone without adequate estrogen can cause weight gain, can cause increased total cholesterol. So that's why the balance must always be there, the yin and yang. Again, effects of too much progesterone, even if adequate estrogen, can also elevate cortisol. All right, okay, or increase carbohydrates and even increase appetite or craving. So that's why balance, yeah? Okay, and if you're always stressed and all that, that's the reason why even if you take progesterone, it's not working because it blocks the progesterone receptors. Okay, testosterone for women, okay? We also need testosterone, not just the man, okay? So I'm going to talk about female androgen deficiency. So testosterone in women is wonderful. It's not just about sex, okay? We want to make sure that we can make the right decision. We have clarity of thinking. We have good decision making. We have good muscle strength. All right, it gives us a good mood. That's what it does. And for women with good testosterone, you have goals, you have things to do, rather than just hide in one corner and say, that's it, life is over for me. So this is where you have to encourage them. So testosterone not just for the man, it's also for us, okay? All right, so again, testosterone production decreases in women with age, okay, together with other hormones, okay, all right. And again, these are some features of testosterone deficiency. You have loss of muscle tone, there's flabbiness, there's droopy head, dry skin, muscle hypertrophy as well, okay, actually feeling down. Some of the sexual symptoms of lack of sexual desires, weaker orgasms, okay, lack of energy, low mood, these are low testosterone. And again, we need to correct the androgen balance, but again, we need to make sure that estrogen progesterone is also balanced. Yeah? All right, okay. All right, so again, how do I give my testosterone? Usually it's transdermal. Okay? All right. Causes of low testosterone women, we have to understand, okay, menopause, childbirth, if she's on oral contraceptive pills, all right, particularly because it elevates the SHBG and just swallows up the testosterone just as well as the estrogen and among other features of other conditions, whether it's estrogen dominance or fibroids that gives rise to endometriosis, yeah? Okay. Symptoms of low testosterone will be just the opposite. That means tired, lethargic, fatigue, muscle wasting, timid, feels like you're a victim, all right? Don't want to go out, all right? Symptoms of high testosterone, too much of good things is no good. Then you get anxious, you get aggressive, okay? Sometimes a woman may present with a bit of hirsutism as well, or even acne, okay? Or some hair loss. How else can testosterone level be raised? Okay, so this is how for a woman you can decrease the calorie intake, you increase protein in the diet, exercise, get enough sleep, lose weight, and treatment of elevated testosterone if she does have. I sometimes do combine with saw palmetto. Okay, and if it's related to insulin resistance, I do add metformin. Okay, SHBG, we have to check SHBG. SHBG is important if you're giving patient bioidentical hormone, because if SHBG is elevated, whatever you give is not going to work. Okay, so you must know that too much. Okay, if SHBG is high, then there is less estrogen and testosterone because all that has been swallowed up. Whereas if there's low SHBG, you have to check your thyroids. Yeah, okay. And sometimes, again, you have to check your progesterone. Maybe that's not enough as well, because if there's low progesterone, there's low thyroid. Okay? All right, testosterone replacement should be transdermal. I use bioidentical, and there's all the literature that says why. Okay? And again, you must make sure that it is balanced with enough estrogen and progesterone. Okay? These other hormones are related to both men and women, DHA and cortisol. For time constraints, I've combined that. Our stress hormones, okay, this is so important. I said just now probably some of you experienced some elevation of these cortisol. The imbalances in the body, stress hormones, adrenaline and cortisol, these are precursors of DHA, and it can cause a variety of symptoms from depression, anxiety, insomnia to no periods as well. Yeah? Okay. So both men and women make DHA. DHA is made by the adrenal glands, and small amount is also made in the brain and in the skin. DHA production declines with age, starting with the late 20s, and by age 70s, 1/4 of the amount of DHA that we make is at its peak. And DHA is extremely important because it makes androgens, progesterones, and testosterone as well for both men and women. Okay, all right. So DHA has a number of other important functions. Okay, so it's again for the immune system. It's doing it for well-being. It's also good for your muscle. It's also important to cope with stress. Okay, and it's also anti-inflammatory. Okay, so replacement with DHA will definitely give you muscle strength, improve your immune system, give you better quality of life, give you better energy, lessen the damaging effects of stress. Okay, and some DHA also has been mimicked, has had the fountain of youth hormone, right? Okay, so that's why it's important. And these are some studies which reviewed functions of DHA, where in the elderly, DHA exerts an immunomodulatory action, increasing the number of monocytes, the T cells, expressing the T cells receptor, and also the natural killer cell. It improves the physical and psychological well-being. And in adrenal insufficiency, DHA obviously is affected. Okay, so that's why there are several studies which shows that in women, okay, who are DHA deficient, if you give DHA, definitely you have better sexual satisfaction, you have better well-being, and also better fertilities. And sometimes for patients with infertility, I even give as high as 75 milligram DHA. And if she conceives, I can even go up to the 16 weeks of pregnancy with the DHA. All right? Okay. So DHA has, because immunomodulatory, as I said, and also anti-inflammatory, it also has protective actions on asthma and allergies. Okay? Next, in regards to the stress hormone cortisol, okay, we all need our cortisol, not coffee. Okay, so if this is adequate, remember this is a hormone that actually improves as you age. All right, but it's one hormone, okay, when one is stressed, is elevated. But if it's elevated 365 days or 24/7, after a while, it's just going to decline. Okay. Now, understanding the functions of cortisol, it balances the blood sugars. It also plays a role in weight control and our immune response. Okay? And again, those women with abnormal cortisol, then also they normally present with eczema, asthma, skin rashes, or even melasma. Okay, so something not what women like as they age, right? Okay. So at the end of the scale, if too high cortisol, you also feel tired. Too low, so you feel tired and you also can't sleep. There's also weight gain and obesity, and also can have an impact on your immune system. Not to mention truncal obesity, but this, of course, again, more of like the Cushinite effect, or even metabolic disorders like diabetes type 2. Low cortisol, on the other hand, will cause also fatigue and lethargy, and also anxiety, or even it can also have an impact on your sleep. So again, too high, too low, both can have an impact. That's why we need to get optimal level. And with regards to mental health, these are some of the issues, like whether it's confusions, whether just inability to cope with stress, irritability, are also some of the symptoms associated with low cortisol. Okay, so what elevates cortisol? Stress, long-term depression. So again, all these chronic conditions can cause damaging effect on the body. What lowers cortisol? Also stress, long stress, because now at one time it's high, but because it's produced so much, after a while it just cannot produce anymore, it just comes down. Yeah, okay. All right, so these are some of the conditions associated with abnormal cortisol: panic disorders, PMS symptoms, infertility, sleep disorders, fibromyalgia, depression, impotence. So when patients have all these conditions, okay, if they can't sleep, don't just give sleeping pill, all right? Okay, so if they have pain, don't just give them painkillers. Understand, go through the history, what's going through, and look at the root cause of it. And that's how we help our patients better than just giving a knee-jerk reaction just because we are licensed to issue out pills. But as I said, pills kills, you see, so use our license appropriately. This is the progression of adrenal fatigue I was mentioning about. In the first stage, there's high cortisol, 24/7, 35, because this is overbooking of it, but after a while it comes down. Okay, and that's where we have the pregnenolone still, so now we have a reduction in DHA, all the other hormones come down, and that's where the patients might even present with amenorrhea, okay, all right, or even infertility. And of course, chronic fatigue, okay, so that's stage 3 where all hormones come down, okay, and that's where she really, or he or she may present with just plain tired. I'm just plain tired. Nothing seems to work the whole day, right? Because I have nothing to start off my cortisol even in the morning, okay. Understand that and remember this, okay? There's a complex relationship, so it's always not treating one hormone. You want to treat one hormone, it's like, you have 4 flat tires and you only change one. It's not going to work, all right? That's why you have to look and do the hormone profile because it works like a web, okay? All right, so here, for example, cortisol is increased, and if cortisol is increased, it decreases the making of progesterone. Okay, that's part of the cortisol steal. So cortisol also competes with progesterone receptors. That's make it worse. Cortisol is elevated thyroid hormone, which is more bound and less active, and its levels can therefore decline. So that's again the association. You see, so that's why we have to do the hormone profile as whole. All right. Okay, so these are some of the, in terms of what treatment, so replacement with either DHA or cortisol, that would be one of the steps that we take. Okay, all right, and also how to balance it. So these are some of the ways that we can actually balance. So again, it's not my intention to actually go through all because the next stage I want to look at is other hormones related to men. So pregnenolone, an important hormone, the major hormone, okay, that affects our memory, or we call it the mother of all hormones, okay. So if you take a lot of statin, it's going to happen. You're not going to have any pregnenolone. It's going to definitely impair your memory, and that's where, and because this hormone further decline with age, giving statins at the age when your hormones are already coming down is definitely a no-no, yeah. Okay, so functions of pregnenolone, again, for energy, again, to enhance the nerve transmission or the memory. So please, please, please remember, okay, do not give statins as freely as it should be. If possible, do not give at all, okay? So again, causes of low pregnenolone are also associated with actually causes of low DHA or cortisol, and these are some of the symptoms associated with pregnenolone deficiency itself, okay, like memory decline and lack of focus and even insomnia, okay. So these are some of the pregnenolone, some of the pregnenolone used in these treatments, and it has been, you can check later on some of the studies I've shown. Okay, with regards to the male hormones, okay, this is just as important, okay, from menopause, now we're going to andropause, okay? So men, no pause, so they padam, okay? Which means partial androgen deficiency of an aging male, all right? So just as the hormones come down in women, it also comes down in men with age, okay? All right, so what happens is there's a 30 to 60% of men in their 70s are already hypogonadal. So if you remember the functions of estrogen for women, the same is also for men. And I'm going to share with you, okay, why it's also important for men to have the hormones, okay? All right, there's also a seasonal variation in the hormones. That means it actually tend to be slightly higher in summer, maybe it's happier time, it's warmer, but also lower in autumn and winter. Don't ask me why, okay, that's thing that has been documented. Testosterone replacement therapy for men is safe and it can provide significant benefits. This is what I'm going to share with you, all right? So there are many causes. Okay, we talk about right from the top, cerebral cortex, the hypothalamus pituitary, the testes or target organs, okay? Aging is one of them, and stresses can definitely also has an impact on your cholesterol level, okay? Testosterone level rise if the man actually achieves a dominant role, but if you have a dominant wife, that's the other way around, okay? The testosterone level comes down, okay? So just check on that, okay? All right, okay. There are also some hypothalamic issues. If there's hyperprolactin level, it can also have an impact on your testosterone level, okay? And some medications also can cause a rise in, can also cause a drop in the testosterone level. The testes, of course, we talk about the damage to the testes, but of course, intakes of alcohol. Alcohol also may have high estrogen levels, and because also impairs estrogen of the metabolism of the hormones in the liver. Okay. So these are also some other conditions that also have an impact on why testosterone is low, okay, and also drugs. Okay, so if you have damage to target organs due to drugs, okay, and this also can have impact. So again, looking at functions of testosterone, like women, okay, testosterone is important for functions of the heart health, whether it's for blood circulation, whether for brain, for memory, for focus, for mental functions, to set goals, to do things in life, for libido, okay, for good erections and orgasms, for metabolism, again, preventions of diabetes, metabolic disorders, and also testosterone is important for the central nervous system with regards to conditions like preventing depressions and all that. Okay, so functions of testosterone are many. Again, like women in, out. So I'm not. You can see up there. So I'm just going to run through this. These are some of the signs and symptoms of menopause and andropause. All right, related to testosterone deficiency. Now, these are important because I'm going to share with you low testosterone levels related. These are some of the studies that shows that you have low testosterone, you have actually related to coronary disease, and a lower total testosterone or free testosterone or bioavailable testosterone, again also higher mortality. Again, low testosterone, okay, are related to the erectile dysfunction and higher cardiovascular risk. Studies reveal that men with coronary heart disease under the age of 45 have a much lower total and free testosterone. The other study shows free testosterone inversely related to carotid intima media thickness. And we have low testosterone, that's why you have also carotid intima thickening. Low testosterone again has increased risk of atherosclerosis. Again, low testosterone. So if somebody has got diabetes in men, you have to check his testosterone. Okay, to the point that in the American Endocrine Society, they said that is actually a definite tantamount that for those who are diabetic, they have to actually check the testosterone level. All right. Again, low testosterone increased risk of all causes of mortality, not just cardiovascular disorders. Yeah, and cancer as well. Okay, low testosterone also has increased risk of hypertension in men. Okay, so these are the things that's happening to you when you have low testosterone. In males with heart failure, low serum androgens were associated with an adverse prognosis. And in men with chronic heart failure, this anabolic hormone depletion is a common condition again, and a marker of poor prognosis. Again, with regards to memory, again, men with low testosterone is associated with development of memory loss, okay, and they tend to be much faster than women than men actually. Yeah, much faster in men than women. Sorry, I repeat, much faster in men than women, okay, in terms of memory loss. Okay, in men, testosterone plays a major role in brain functioning in terms of if there's subclinical androgen deficiency, that's why you have the increase in the production of the beta amyloids, and that's what's increased risk of also Alzheimer's. Yeah, okay. Again, regards to testosterone deficiency and memory, there's also an impact on visual and verbal memory loss again, okay, and Alzheimer's. Again, these are all the studies that shows how important testosterone if you want to prevent Alzheimer's, such that in America they said that 6 million men over age 65 have Alzheimer's, 1.8 million currently, okay, and by 2050 the number of people age 65 older with Alzheimer's may triple, okay, and that would increase to 5 million. That's critical. That's scary. Okay, testosterone and also importance in terms of spatial performance and mathematical reasoning. Again, men with low testosterone. See all these issues related to low testosterone. So that's why testosterone replacement is important. Very, very important. Just as in terms of estrogen replacement therapy. Okay. All right. Again. Okay, so you want to have better memories? Make sure you have your testosterone up. Okay, so how do you give testosterone? I'll talk about pregnenolone and the role of DHA in male hormones. So again, just remember, okay, these are some of the lab work that I do in terms of before I start them on anti-testosterone, and also understand the role of the aromatase enzyme. How, if you give testosterone, you have to check this because otherwise, if you give too much testosterone without checking your SHBG and estradiol, okay, then you might not understand why the man is not getting the effect, you see. So, because the male also needs estrogen, but too much of it is bad, okay. So that's where the risk of like benign prostate hypertrophy or even prostate cancer also can occur. So the bigger the man, the more fat you have, the more aromatase enzyme, the more if you give testosterone, it's going to be changed to estradiol. Right? So that's why you cannot just check estradiol. You still cannot just check the testosterone. You have to check the estradiol. All right? And again, understand how testosterone is converted to estradiol. And estrogen on this. That's the pathway there. Okay? And again, so if you have too much estrogen, it can actually have an impact on his erections, the orgasm, the production of the sperm. Okay, that can be decreased, and that also can have an impact on his libido. Okay? So these are some things that can lower that can actually help to prevent conversion of testosterone to estradiol. Okay, so not unusually I do combine testosterone with some of chrysin to prevent that conversion. And these are the conditions, if the men are coming in with metabolic disorders or hypertension or diabetes, that means he probably have increased aromatase as well. So that's why you have to ensure that these are also checked and prevented. So estradiol have a protective effect on the brain, but too much of it can cause problems in men as well. Okay, so these are some of the medications that may lower estrogens levels in men and cause estrogen levels to be too low, but because you don't want too low and at the same time you don't want too high. All right, this is an unusual study, but something that I'm going to think about. This is experimental at this time, but there's also probably a role of it in autoimmune condition. Okay. So these are some of the conditions where estrogen levels are elevated in males. Okay, we have to take note of that and how we have to overcome that. Okay, all right. So because too much estrogen is damaging to them, it's too little. Okay, so estrogen levels may elevate as men age, and there are all these xenoestrogens, all these chemicals and environmental factors. And if the wife is forever mopping the house and he's walking around barefooted, that's where you can get xenoestrogens absorbed through the sole of the feet, because that's where the pores of the sole of the feet are bigger. And plastic containers, drinking from plastic bottles and all that. So these are the things that are harmful to us, harmful to the men and women as well, in causing abnormal hormonal imbalance. Okay, so elevated levels of estrogen in males are associated with various conditions, whether it's gynecomastia, decreased libido, the decreased orgasm, okay, or BPH or prostate cancer. Of course, the belly fat there. All right, and these are some studies that show that high estrogen in men are associated with even increased risk of stroke. Yeah, okay, not just prostate issues. So elevated levels of estrogen in men are also associated with increased incidence of strokes, peripheral vascular disease, and carotid artery stenosis. Another study shows also high estrogen levels in males are also associated with peripheral artery disease in older men. Okay, so these are some of the ways that you can actually lower the estrogen in males through the aromatase enzyme, whether the cruciferous vegetables or the alums. These are the things that what can be given to them. Okay, and these are some of the studies on testosterone replacement, where definitely it can improve the cognitive function, it can prevent beta amyloid precursor, and that's how you can actually reduce the risk of Alzheimer's. Yep. Okay. Studies on testosterone replacement that also shows that it can help in cognitive function and overall also improve on not just cognitive function, but also verbal fluency. Okay, all right. Okay. More studies here. How testosterone plays a very important role in also preventing coronary artery disease. Okay, and just showing you what else, how important. There's so many studies that shows that why you need testosterone, okay, to reduce inflammation, to reduce total cholesterol, to reduce bad cholesterol, and why it's totally relevant, and also the role of how it can also, if balanced properly, can also prevent prostate cancer. Okay, again, testosterone insulin resistance. If somebody has insulin resistance, you have to give testosterone, otherwise it's not going to work. So that's why it's important to have testosterone replacement, because it decreases insulin resistance. Okay, so basically testosterone replacement is either transdermal. There are many ways of doing it. Okay, transdermal again is more effective, but you can give oral or even IM, but depending again how the patient comes in. So this is the combination that I normally give, just testosterone that I either in cream. I rarely use transdermal. I rarely use what we mean in terms of patches. Not unusually, sometimes just give a boost. I do give IM testosterone sometimes because and among some of them, I even give Nebido, which in actual fact, particularly if they are coming from outstation, and why? Because it does maintain testosterone level consistently with normal physiologic roles. Okay, but again, be careful. Do the checkup to make sure that there are no contraindications to giving that. Okay, this is how testosterone can be given in terms of the IM. Okay, all right. So contraindications, be aware in terms of to ensure that these are there are no underlying conditions. That's why this has to be excluded before it started. Depending on if the patient is coming with infertility issues, if it's young, not unusually, this is where there is an option to consider giving clomiphene. Okay, but again, it does not work in men over. If they're older men. So here, what they do is that clomiphene blocks this. So this is what happens in the end. The pituitary sees less of the estrogen, so increase LH. LH, of course, will increase the Leydig cell, more testosterone, and increase FSH also will increase spermatogenesis. So this is an option. So clomiphene is not only for women. Yes, we can also consider that for male with infertility issues as well. Okay, especially if they have hypogonadism. All right. Okay, what else? Some possible side effects that we have to check on. Again, these are the things that you have to, but they are usually very, very rare, yeah? Not unusually, sometimes, yes, in younger men, you can also consider giving HCG, all right? Okay, and again, this is where HCG does not cause loss of testicle volume, as opposed if you give testosterone long term in younger men, of course you can also get testicular atrophy. And HCG does not decrease in sperm count, so HCG needs functioning Leydig cells to work. So that's why we have to measure the FSH LH. And only in these conditions, if LH, if the LH is if the LH is less than 3, that means then HCG usually gives good result. That means that's the reason why HCG is one of the indication. This is how it normally is given, 2,000 to 500,000 units. So these are the options, 1,000 twice a week. Okay, and in terms of depending on the individual protocols of how you want to do it. Okay, beware of, again, the side effects. Okay. All right. So these are some natural ways to increase testosterone and suppress estrogen. I mentioned some already. Okay, zinc is one of them. Okay, so lacking of zinc also will have cause. That's might be associated with lack of testosterone. Of course, when you do give men testosterone replacement, you have to check the hematocrit. You have to check also the fibrinogen. These are some of the things that I do on a regular basis to ensure that they don't have these complications. Because if you do, that's where you slow down, or you actually lower down, or you even actually stop the testosterone for a while. Okay, so conclusion: estrogen, progesterone, testosterone, DHA, cortisol, all hormones are important, not just for women but also for men. All right, so these are some of the ways you can keep your hormones productive. That means good lifestyle, de-stress, and sleep early. Make sure that you also take the right supplements, because you need to support the liver functions to help in the detoxifications of the metabolites of the hormones. All right, and maintain a good healthy weight. Appropriate balance. Just to share, just go through again in terms of understanding that this hormone works as a web. This all needs to be balanced in terms of the estrogen and progesterone. Okay, and again, and associate all the other hormones, right down to the thyroid hormones as well as the growth hormones. Okay, so even bioidentical hormones has got this risk. That means if you give too much or if you give too little, all right, that also causes problems. Okay, so if you also give the wrong mode of administration, that's why I said when it comes to bioidentical, estradiol, transdermal is the way forward. If you give too much and an imbalance, of course, it can also cause problems. Other areas, inappropriate route of administration will cause inefficiency and also more complications, particularly to the liver. And appropriate routes of administration is the choice. So this is what I mean. If it's estradiol, it's transdermal. If progesterone, preferably vaginal, but those have issues with sleep, then per oral. All right. Okay. So testosterone, preferably also transdermal, injectable is the second best. All right. So and with regards to routes of administration, this again, the preferred route for DHEA and cortisol, all right? Oral rather than transdermal. Okay, so remember, it's all about balance, because if you have imbalance, you have more side effects rather than helping. Example is this: you get imbalance of this, increase of breast cancer, imbalance of if there's patients with secondary adrenal deficiency have increased serum testosterone. So these are the things that we have to make sure that we're not given excess, because then we'll have more side effects. Okay, so excess dose, as for any other treatments, okay, this is what can cause. I've gone through just a summary. All right. So with regards to what I have mentioned as a whole, so all of the hormones in the body, they were designed to work together. I said they work like an orchestra, a symphony, okay? So, and the major conductor, of course, is the thyroid hormones, but I'm not talking about thyroid now, I'm just saying that what we need to say is that, yes, we have a major conductor, but we also need all other hormones to work together, okay? So you cannot take one and balance one without the other. So you have to preferably also to make sure that when you start, you look at the major hormones that you need to start off and make sure that that is actually given appropriate balance. And that's where we'll make the patient, or rather improve their quality of life. Okay, humbly, these are my references. Okay, I actually, Prof. Fred is here, your good friend, is also my great teacher, all right? Among other things, also Pamela Smith, okay? And these are the teachers I actually owe a lot of in terms of my clinical practice with. And I'm just so happy, I'm just too excited to share with you that he's here in town. It's a very rare opportunity to see him. If you want to go and see him, you have to probably, even a consultation with him probably will cost about €1,000, and you have the opportunity to learn from the best. He's the world best because he's of course he's the president of the International Hormone Society in Europe, but he's also on the medical board in US and with Pam Smith also. So and if you have this opportunity, it's a gift. So do not throw this gift. I have nothing to gain monetary for it. If you all attend this and you do better, I may have a little gift maybe in the hereafter. Thank you very much for your time.
Thank you.
Thank
Thank you so
you.
much for Dr. Nora.
Thank you, Dr. Nora.
Yeah.
We shall allow 2 questions maybe, since we're running out of time.
Okay, please get to the microphone if you do have questions. Hormones is a very exciting thing. We usually need a full day just for what she spoke about.
Yeah, no, and they all know.
Yes.
No questions? Okay.
Maybe I'll ask a question. Dr. Longer talked about growth hormone being a problem. What is your view on that? You haven't talked about growth hormone.
Yeah, correct. I agree because as a time constraint, I actually talk about the steroidogenic pathway. Growth hormones. I mean, he says it's a problem, but it's only a problem when we abuse it. Anything is a problem when it's abused. Otherwise, it's something that I do actually definitely we have to look at growth hormones. Of course, it's not stable, so we measure the insulin growth factor, and naturally we can try to improve that. In terms of giving the precursors to it, but good quality sleep, exercise, and even giving GABA. So giving GABA in conjunction with melatonin has been shown to quadruple the level of IGF. So that's one way. So and if in those patients who are actually really quite resistant to it and having severe growth hormone deficiency, I also give them insulin growth injectables. So I again, Edward, all right, there's a point of contention. So as I said, it's. I mean, you have to look at the as a whole, and I think there's a place for growth hormone replacement.
Thank you.
Yeah, if IGF is.
Next question, please.
Yes. Comparing taking growth hormone using bioidentical hormone replacement therapy and fasting, because there are a lot of studies mentioning that intermittent fasting will also increase our growth hormone around to 100%. Which one you think is the more safer?
Sorry, I didn't get your question. What increase growth hormone to 100%?
Comparing taking growth hormone using bioidentical hormone replacement therapy with intermittent fasting.
Yes.
Which one you think is much safer? Because there is a lot of studies mentioning that intermittent fasting will also increase our growth hormone around to 100%.
Definitely. Okay, intermittent fasting can increase also growth hormone, but not everybody can do intermittent fasting. Yeah? So what I found out now, which I think is also quite easy to take, is actually GABA with melatonin. And I see that definitely within 4 months, there's an increase in growth hormones, even if they don't exercise. But overall, okay, if the patient is patient, and if she's compliant or he is compliant to it, for younger patients, when you balance all the other hormones, the growth hormones also will improve now that they're sleeping better, because there's a correlation between melatonin and growth hormones. So if you sleep better, your growth hormones can improve. But again, in older patients, it's quite resistant and it's too low, this is where I add on GABA. Yeah?
Okay, once we take growth hormone or other hormones, does it mean that the whole of our lives we will dependent on that kind of hormones?
Very good questions. And you're not the only person who asks that, because my patients ask that most of the time. And I always tell my patient, take it for 6 months. Because in 6 months' time, God knows what's going to happen. There might be new technology, new thing. I just need one cell and that's it, I'm rejuvenate. Okay? So be patient. This is what you require now. Take it. Okay? You start this tomorrow and stay on it if you want to see the results. Because it's not going to happen overnight. It's going to happen over time. And only if you're consistent, your perseverance, and you're patient, you will get results. All the patients who are actually on track, they get results. Right?
Okay, thank you.
You're welcome.
Okay, for
Hello.
the last question.
Okay. Just now you mentioned about chemotherapy, radiotherapy can cause deficiency in testosterone among breast cancer patients. Okay. What is the option for them to increase the testosterone, especially those having so-called anxiety, so depression during that particular time?
Okay. All right. Because it's not just testosterone that causes anxiety and depression in kids. So when they're on chemotherapy and radiotherapy, it's multiple factors that's actually causing those issues. So you have to look into socially, the background, the family support, is there issues with that, the kind of food that she's taking, because again, that also contributes to her general well-being. And if ever, I do give hormones even if they have cancer, particularly those that are will support the immune system, such as melatonin or 7-keto-DHA for better energy. Right. But I actually do refrain from giving estradiol, progesterone, or testosterone. Yeah.
Thank you.
Welcome.
All right. Thank you. With that, I would like to invite Dr. Mazia to deliver a token of appreciation to Datuk Nora. Please welcome. Oh, all right. So this time is Dr. Homer accompanying and Dr. Mazia. Please. Thank you again for
Thank you
that.
again.
Right. Next, Michelle, we shall go.
Okay.